Hello, everyone. Hello, sir. Good day. My name is Ronald C. Solomon, and welcome to my case study presentation. Let's proceed with our discussion. So, we will be more focused on history of the patient, chief complaints, diagnosis and procedure, and lastly, we have the patient position and schedule of arrival. My case study is all about CT abdomen with contrast. Our case is acute cholecystitis. History of the patient is that patient admitted with a 3-day history of acute abdominal pain with no previous medical history. Right upper quadrant pain with normal bowel sound. Murphy's sign was positive. For those who don't know what does Murphy's positive. It is a elicited in patient with acute cholecystitis by asking the patient to take in a hold and deep breath while palpating the right subcostal area. If pain occurs on inspiration, when the inflamed gallbladder comes into contact with the examiner hands, that means that Murphy's sign is positive. Next, we have chief complaints, right upper quadrant pain. Diagnosis for this case is acute cholecystitis with a mucosal ulcer. Procedure is that the physician or the doctor will request a CT upper abdomen with contrast, and position of the patient should be supine position, arms up. Fasting is also required for 8 hours fasting time. Paraphernalia none. Schedule is 8 a.m. and arrival is 7:30 a.m. Let's proceed with the imaging protocol. CT scans were performed on either RSDECT or DLDECT scanners. RSDECT is a single source rapid switching dual energy scanners that uses fast kilovolt peak switching to acquire dual energy data by modulating the voltage of a single X-ray generator from low to high kilovolt peaks between alternating projections. DLDECT CT scanner uses a dual layered or DL detector array to create a spectral projection data from a conventional 120 or 140 kVp scan. Images were acquired in the portal venous phase after administration of 100 ml of iopodimol 76%, Isuvu 370 GE Healthcare, injected at 3 ml per second with 30 ml of pre and post saline fish. Blended CT reconstruction were generated to simulate conventional images acquired at 120 kVp on a single energy CT. Post processing was also performed at the CT scanner to generate low keV or RSDECT 50 keV or and DLDECT is 40 keV and iodine density maps. All set of images were reconstructed at a slice thickness of 5 mm and were sent directly to PACS. This is the image of right upper quadrant pain and fever who underwent contrast enhanced CT of the abdomen and pelvis. As you can see on the letter A image, this is a shell simulated conventional CT image shows thickened and edematous gallbladder wall and no evidence of gangrene. On the letter B image, axial iodine overlay image shows focal lack of iodine uptake along the posterior gallbladder wall, or as you can see on the arrow. That means it's confirmed as gangrene on histopathology. On the letter C image, you can that is a shell 40 KeV virtual monoenergetic image shows focal lack of mural enhancement along the posterior gallbladder wall, or as you can see on the arrow, that means and that is confirmed as a gangrene on histopathology. That would be all for my case study report. Thank you so much for listening.